بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we'll talk about the sport injuries around the hip joint, and this is an important issue, especially for the therapists and the sport medicine physicians, and also for the radiologist and musculoskeletal imaging specialists. Actually, I didn't expose much of this topic in the lecture about the imaging of the hip, and also I didn't uh, fully explain this topic while I'm talking about the adolescent hip. Then you know that we have the 3 or 4 imaging modalities which can be used in this domain, including the X-rays and ultrasound, as well as CT and MRI. For X-rays, they are helpful in the detection of fractures, also in assessment of osseous tendon avulsions, some of the arthropathies, the issue of avascular necrosis, and the assessment of femoroacetabular impingement. And this is just an example of the plain X-ray of the left hip showing avulsion of the anterior superior iliac spine. Of course, you know that ultrasound has many advantages over most of the imaging techniques, including that it is a fast procedure, very sensitive technique, and non-invasive, using no ionizing radiation. Also, it is a portable machine, can go to the patient anywhere with this extremely important facility, which is the real-time dynamic imaging, and also the presence of the Doppler facility for assessment of vascular pathology. Then you will see that ultrasound has an important role, especially in diagnosis of the snapping hip, and also in many of the tendon and muscle tears. CT is one of the important modalities for assessment of the skeletal system. It helps in the detection of fractures that are not detected or could not be detected by X-rays. Also, using the reconstructive capabilities of CT, it is used in preoperative evaluation of complex fractures around the hip or any part of the body. It can identify intra-articular loose bodies if they are calcified, and in patients in whom MRI is contraindicated, CT arthrography can be used for assessment of the internal derangement of the hip joint. MRI is one also of the major tools, and it is one of the important imaging modalities for evaluation of sport injuries anywhere in the body. It helps in detection of subtle fractures because of its major sensitivity for bone marrow changes. Also in assessment of avulsion injuries, tendon and muscle injuries, labral pathology, and ligamentous pathology, the evaluation of femoroacetabular impingement, and the use of MR arthrography for evaluation of the labral tears, and also evaluation of the injuries of the ligamentum teres. One of the important issues to be taken into consideration is that if you inject intra-articular anesthetic, together with the contrast media, and you got relief of the patient pain, then you are almost sure that the cause of pain is intra-articular in origin. These are the usual indications for evaluation of any joint in the body, including pain, history of trauma, swelling, and suspected infection or tumors. And we use the body coil for evaluation of both hips together. And we have five types of MRI: the closed machine, the open machine, the extremity machine, and the dynamic one, where you can examine the hip joints and also the spine in the upright position. And this is the protocol for evaluation of the hip by MRI. We should have two coronal sequences, the T1 and the stir images. This is T1 and this is the stir image. Then we may have two axial sequences, the proton density or the T2 or the T2 star. And sometimes one may have an axial T1. Also, we have a single sagittal sequence, which I think should be the T2 for the diseased hip or for both hips if they are involved by pathology. We do not usually need to inject contrast material whenever we are evaluating sport injuries. And you remember that we have certain structures that will appear black in all MR images because of the absence of mobile protons, and these are the cortex of the bone, mature fibrous tissue, and calcification. And we add to this list the acetabular labrum. Then fluid will appear of low signal in the T1 and high signal in the T2, like the urine in the urinary bladder, in the synovial effusion, any cyst in the vicinity of the hip joint, and so on. The opposite of fluid is fat, and fat will appear of bright signal in the T1 and the less bright signal in the T2 weighted images. And these are the pulse sequences used for evaluation of the hip. The T1 where the bone marrow is bright, the T2 where the bone marrow is gray, the T2 star or gradient image where the bone marrow is more darker, then the star image where the bone marrow is jet black, and both or all these three images belong to the T2 weighted image. And the hip anatomy is very simple because we do not have too much anatomy here. We have the acetabulum, which covers about 40% of the femoral head, and the acetabular is deepened by the acetabular labrum, which is a fibrocartilaginous structure. We'll discuss it in full details. And you should know that most of the femoral neck is enclosed within the hip joint capsule. And some of the muscles that, let us say, a little bit important around the hip, like this muscle, which is on the inner aspect of the acetabulum, which is the obturator internus muscle. And anterior to the hip, you get the pectineus muscle, and this is one of the important muscles, which is the iliopsoas, which is located just lateral to the femoral vessels. And then lateral to the iliopsoas is the rectus femoris, and anterior is the sartorius, and then you got the tensor fasciae lata and the vastus lateralis. This is the gluteus maximus muscle in this area. Then in the coronal image, we would like to emphasize the obturator internus, the obturator externus, the adductor brevis, the adductor longus. And these are let us say, the most commonly injured muscles in sports related to the hip. Then we will try to discuss these items. First of all, the stress fractures, then the adductor insertion avulsion syndrome, then the sequelae of posterior hip dislocation and subluxation, then the apophysitis or apophyseal injury, the femoroacetabular impingement, acetabular labrum injuries, ligamentum teres injuries, greater trochanteric pain syndrome, muscle injuries, Morel Lavalier lesion, snapping hip syndrome, and finally the athletic pubalgia. Of course, the stress fractures are common in the region of the femoral neck, and they are especially encountered in long distance runners. They affect mainly the medial aspect of the femoral neck, but sometimes they occur on the lateral aspect as well. In most of the cases, the fracture is occult on the uh, plain X-ray, and you cannot, many times you cannot see the fracture line for sure. But MRI, because of its sensitivity uh, to the bone marrow edema, then it will show at the beginning some of the edematous changes at the possible site of the fracture, and later on it will show the fracture itself. Then here you can see the bone marrow edema, but you cannot see the structure, the fracture itself. And there is a grading for the stress fractures of the femoral neck. They include the grade 1 injury where you got minimal periosseous edema, which of course is best seen on stair images. Then you get subcortical bone marrow edema, this is grade 2, and extensive periosseous edema and bone marrow edema, the combination of both, and this is grade 3. Then whenever you see the fracture, you are in the grade 4. And of course, high-grade injuries like grade 4 requires longer period of rest, cessation of sport-related activities, and non-weight bearing technique. And if you look carefully here and you want to localize the site of stress fracture in the femoral neck, I think you cannot actually detect the exact location of the fracture. But let's look to the CT coronal reconstruction, then you can see the site of the stress fracture, and also you can see it very well in the MR images surrounded by bone marrow edema, which is black in the T1 and bright in the T2 weighted image. Then we came to the second issue, which is known as adductor insertion avulsion syndrome. The adductor muscles insert in the medial aspect of the middle third of the femoral shaft. Then due to repeated micro trauma and the stress related to the muscles, there will be some changes at the adductor insertion, ranging from uh, just edema at the tendon and some periosteal reaction up to complete avulsion of the adductor muscle. Then in the plain X-rays, you may not see any abnormality apart from localized periosteal reaction to the insertion site. On the bone scan, you will see some increased uptake along the posteromedial aspect of the femoral shaft corresponding to the site of the adductor insertion. Then on MRI, you will see edema at the insertion site, and you may also see bone marrow edema of the femoral shaft, and sometimes you got edematous changes of the muscle itself. By plain X-ray, you only see some perosteal reaction along the posteromedial aspect of the femoral shaft, and here you can see some perosteal reaction by CT together with periosteal or periosseous soft tissue edema by MRI stir image. And this is the coronal image showing bone marrow edema as well as periosseous soft tissue edema. Then you came to the sequelae of posterior hip dislocation and subluxation, and this is an uncommon injury usually seen in contact sports and is commonly mistaken according to the literature for a sprain or strain of the muscles around the hip. This injury is very important because of its sequelae, where one of the major sequelae of this injury is a vascular necrosis of the femoral head. The CT scan is able to demonstrate the fractures that happened on top of dislocation or subluxation of the hip. As you can see in this example, there is a fracture of the femoral head itself. There is fracture of the posterior margin or posterior column of the acetabulum, and there is another bone, free bone fragment here. MRI, because of its sensitivity to edema and the hemorrhage, can show joint effusion, can show hemarthrosis, and can show bone marrow edema. And then if you uh, see bone marrow edema in the femoral head, then according to the literature, you may have to have a follow-up MRI within or after 3 months to be sure that the femoral head is viable. Also, you can use the dynamic contrast enhanced MRI to assess the vascularity and the blood supply of the femoral head when if you see hypoperfusion of the femoral head, and this is considered one of the early signs of avascular necrosis. If these patients are examined by arthroscope, there is a possibility to detect labral tears, condyle disease, ligamentum teres injuries, and also intra-articular loose bodies. This is an example of posterior hip dislocation associated with a fracture of the quadrilateral plate of the acetabulum together with rupture of the posterior column as well. Then, what about apophyseal injuries? You know that the physis, which is present between the epiphysis and the metaphysis, is weaker than the adjacent tendon or bone. Then repeated microtrauma or traction applied to the muscles related to the certain physis will result in this injury, which is considered as Salter-Harris type 1 injury. You know that the apophysis of the iliac crest give attachment to the abdominal muscles. The anterior superior iliac spine gives attachment to the sartorius, anterior inferior iliac spine to the rectus femoris, the greater trochanter to gluteus medius and minimus, the lesser trochanter to the iliopsoas muscle, the ischial tuberosity to the hamstring muscles, the symphysis pubis to the adductor muscles. And what happens if you apply stress to the apophysis? Then you got separation of the physis, and this, as you remember, is considered a Salter-Harris type 1 fracture, where you get distraction of the physis and widening of the physial plate. Then after that, there is some tissue response which will result in formation of some perosteal reaction and attempt for healing, and this is considered by some a sort of apophysitis, which is not an infection or an inflammation. It is just a reparative process to for trying to heal the separated phyces. Then sometimes you got normal X-rays, and you can see the separation of the phyces compared to the normal sign. And in chronic states, you get a good amount of bone, which is deposited here, trying for healing. And this is considered by some the most the most common position that may lead to sometimes injury of the phyces, where you got a lot of stress here on the on the hip. And here is an avulsion fracture of the anterior superior iliac spine on the left side, and this is the follow-up examination. You can see the amount of bone trying to bridge the defective area and to get healing of the separated apophysis. And this is also another example of avulsion fracture of the anterior superior iliac spine. Sometimes you cannot see these changes on the plain film, but you can see the changes on MRI, where it is easy to identify bone marrow edema of the related metaphyses and soft tissue edema surrounding the site of injury. Then we came to the femoroacetabular impingement, and I think this video will explain very well the different types of femoroacetabular impingement.
The hip joint is made up of the femur, the pelvis, and soft tissues called the articular cartilage and the labrum. The labrum is a rubbery ring of cartilage that seals the joint. It also acts as a shock absorber. The cartilage and labrum allow the hip bones to move smoothly. If these bones are in an abnormal shape, they can damage the soft tissues, cause pain, and limit the range of motion of the hip. This is called a femoroacetabular impingement, or FAI. There are 3 types of FAI. The first, called a cam lesion, is when the neck of the femur is thicker than it should be. The lesion can pinch the labrum and damage the cartilage. The second, the pincer lesion, is when there's extra bone at the edge of the socket. It can also pinch the labrum. The third type, the subspine lesion, is when an area of bone just above the socket, called the anterior inferior iliac spine, is too large. The labrum and soft tissues can get pinched between the femur and extra bone. Every patient's FAI is unique and can be a combination of these types. We don't know what causes FAI, but it seems to develop as a person grows. FAI is not caused by an injury, but symptoms can get worse with increased activity. To confirm if you have FAI, a doctor can perform a physical exam and use imaging like X-rays, MRI, or CT scan. Physical therapy can help manage pain and improve muscle function, but in some cases, people need surgery. One option is called hip arthroscopy, a minimally invasive surgery. First, your surgeon will make 3 small incisions, 2 for the instruments and 1 for a camera. Next, the surgeon shaves down the extra bone. This smooths out the shape of the joint and improves the range of motion of your hip. And finally, if your labrum is torn or detached, your surgeon carefully stitches the labrum back to the edge of the socket. At Children's Hospital Colorado, the team at the sports
Okay, then we have two types of femoroacetabular impingement. The first one is known as the CAM type, where there is an abnormal bone that is related to the junction between the head and the neck of the femur along its the superior aspect, and this will interfere with the movement of the hip joint, resulting in degeneration and maybe tear of the related acetabular labrum. And this is an example of the CAM type where you see a bump or a bony protrusion at the junction between the head and the neck of the femur comparing to the normal appearance. The causes, as you heard, are usually idiopathic, maybe developmental, maybe the sequelae of trauma, maybe the sequelae of diseases in the hip like Bursa's disease or slipped capital femoral epiphysis, and sometimes it may be iatrogenic in origin. Then if you look carefully here, and you can see that there is a bony protrusion which is located between the junction of the head and neck of the femur along the superior aspect. And this condition may be bilateral, where you got a bump here and another one on the right side. This is usually simulated by the pistol grip deformity of the femoral neck, where you got this bony protrusion in the superior aspect of the femoral neck. And this is also the example of bilateral affection of the hip joints. The second type is the pincer type, where you got some bone which is related to the superior margin of the acetabulum, resulting in more acetabular covering of the femoral head, and this will interfere with the hip movement and result in early degeneration and tear of the superior acetabular labrum, and later on it will result in what's known as the countercoup lesion, where the inferior acetabular labrum, the anteroinferior acetabular labrum may be also affected. Then here you can see that the acetabulum is covering much of the femoral head, and the causes are also idiopathic, developmental, and this is protrusia stabile is one of the conditions, traumatic or over correction of retroversion in cases of hip dysplasia. And in order to assess the acetabular coverage of the femoral head, you consider that the femoral head as a circle, and you put a dot in the center of the circle, and you draw a vertical line, perpendicular line from this dot. Then you connect this dot to the superior margin of the acetabulum. And you measure the angle between these two lines, and this angle normally should not exceed 39 degrees. But if the angle is more wide, then you got more coverage of the acetabulum to the femoral head. Then, and this is what I have just mentioned now, then you may have the combined type, which is both the CAM type, see the protrusion, and the overcoverage of the acetabulum, as you can see here. Both types may occur together. Now, we came to the acetabular labrum, and the labrum is a horseshoe fibrocartilage that is triangular in cross section. Its thickness is about 2 to 3 millimeter, and it is usually defective or discontinuous inferiorly, where it blends with the transverse ligament. The acetabular labrum is one of the major stabilizers of the hip joint. If the labrum is injured or degenerated, this may result in a hip instability. The causes of labral tears include as I have mentioned, femoroacetabular impingement, trauma, hip dysplasia, hyperlaxity, and repetitive overuse injury. This is the normal appearance of the acetabular labrum by hip arthrography, MR arthrography. You see a triangular structure that is of black signal in all pulse sequences in the T1, T2, T2 star, and stir images. And this is just a description of the zonal anatomy, let us say, of the acetabular labrum, dividing the acetabular labrum into 5 zones. Zone number one, which is anterior, number two, anterosuperior, number three, the superior, number four, posterior superior, and number five, posterior labrum. And you know, the labrum is deficient, is not present in the inferior aspect of the hip, and this is the site of the transverse ligament. You know, the most common sites for injury are the anterior and the anterosuperior and the superior parts of the labrum. Then, as I have mentioned, the labrum is hypointense in all bulk sequences, and it appears as a triangle in cross section. The most commonly sites of labral injuries are the anterior and anterosuperior sites. Then one of the most important landmarks of labral injuries is the extension of the injected contrast material into the substance of the labrum. This is the normal appearance of the acetabular labrum, a triangular dark signal attached to the margin of the acetabulum. And this arrow points to one of the common normal findings where you got some attachment of the hip joint capsule at the base of the labrum, resulting in some of the contrast material is present between the labrum and the capsule, and this does not indicate that the labrum is injured. This is absolutely normal labrum, and this is a normal finding. Then if you see the contrast material, this is the acetabular labrum, anterior one, and you got some contrast material going through the base of the acetabular labrum, then you know that the labrum is partially torn. And here is a detached anterosuperior labrum. You see there is no more attachment of the labrum to the acetabulum compared to the posterior one, which is intact, and you got some contrast material running through the substance of the labrum and also at the base of the labrum, denoting labral detachment. And this is the normal appearance of the labrum in the sagittal view. Then here you also got severe degeneration of the acetabular labrum, as indicated by its relatively small size and abnormal signal. The labrum is not separated from the acetabulum, but it is severely degenerated. And this is another example of labral tear, where you got separation of the base of the labrum and contrast material is passing through or between the labral base and the acetabular rim. And one of the signs of labral tears is the presence of a collection of fluid at the site of the injured labrum, what's known as the paralabral cyst. And the paralabral cyst is considered one of the diagnostic criteria suggestive of an associated labral tear. And you can see here in this sagittal image, there is detachment and let us say laceration of the anterior labrum, and you got this big cystic component related to its site, denoting a paralabral cyst. Then we came to the ligamentum teres, and this is the ligamentum teres. It is an intra-articular ligament arising or attached inferiorly to the transverse ligament and goes upward to attach to the fovea capitis in the femoral head. its length is in the range of 3 to 3.5 centimeter, and it is thought to help in the stability of the hip joint. Injuries of the ligamentum teres are in the range of 4 to 15%, and the uh, the MRI is considered the best modality for evaluation of ligamentum teres pathology. And also you may got some of the secondary non-specific signs of ligamentous injury, including hip joint effusion and surrounding soft tissue edema. Then this is the normal appearance of the ligamentum teres, which is attached to the transverse ligament inferiorly and the fovea capitis. Upon abduction of the hip, the ligamentum teres gets tightened and stabilizes the inferior aspect of the hip joint. And here, this is the normal appearance of the ligamentum teres in the coronal image, and also in the axial image you got a cord-like dark signal structure related to the fovea capitis. Then if you look to the ligamentum teres here, and you see that the ligament is swollen and it's not of dark signal, and then you got degeneration or sprain of the ligamentum teres. And sometimes ligamentum teres is congenitally absent, like in this hip joint, compared with normal appearance of the ligamentum teres. And here is degeneration of the ligamentum teres, it's swollen and of gray signal compared to the normal one. And this is an example of a partial tear in the ligamentum teres. You see contrast material running through the substance of the ligament. And also this is a good example of a partial tear of the ligamentum teres. You see the contrast material going inside the substance of the ligament. Then we came to what's known as greater trochanteric pain syndrome. In the greater trochanter, in the region of the greater trochanter, we have two muscles inserting into the greater trochanter, which are the gluteus minimus and the gluteus medius muscle. And there are three bursae around the greater trochanter, one related to the gluteus medius tendon, and another one related to the gluteus minimus tendon, and the third one covering the outer aspect of the greater trochanter. Then any lesion that may affect the bursa or affect the tendons will result in this syndrome, which is known as greater trochanteric pain syndrome. Then the expected lesions include bursitis, include tendinitis of any of these tendons, include tendon calcification, calcific tendinitis, partial or complete tendon tear. All these abnormalities can occur at this area, resulting in this particular syndrome. And this is an example of gluteus minimus tear, gluteus medius tear, tendon tear, where you see fluid signal surrounding the tendon, which is not reaching the insertion site in the greater trochanter. And this is an example of trochanteric bursa. The bursa is inflamed and it accumulates fluid, as you can see, around the greater trochanter. And also calcific tendinitis of the gluteus medius tendon, and this as seen in the plain X-ray and also in the CT scan. And this is gluteus medius tendinosis, where the tendon is relatively swollen and is of gray signal, and it can compare to the normal appearance of the tendon itself. Then this is an example of the gluteus minimus tendon, which is intact, but there is some fluid density, signal intensity around the tendon itself, denoting peritendinitis. And sometimes in this disease, which is sometimes called the chondrocalcinosis or calcium hydrate pyrophosphate deposition disease, you got calcification at the site of the tendon attachment to the greater trochanter, and in this particular disease you got bilateral and maybe symmetric calcification of the gluteus medius tendons. And you can see here there is calcium bilaterally, and this is usually a self-limiting disease, meaning the calcium can resolve later on. Then muscle injuries represent about 30% of sport-related injuries around the hip, and you know that the musculotendinous junction is the weakest point of the muscle. Muscle injuries may present clinically by muscle soreness, tenderness on palpation, weakness and swelling, and potential loss of function in high-grade injuries. And we have three grades of muscle injuries. The grade 1 is just muscle edema. Grade 2 is an intra-substance hematoma. Grade 3 is muscle laceration and retraction and later on atrophic changes. Then muscle edema is the whole landmark of grade 1 muscle injury, and of course the best way for diagnosis is MRI. And if you look here, and you can see the biceps femoris muscle in the coronal image, which has a fizery appearance. This is the tendon of the muscle, and this area is the myotendinous junction, which is the weakest point and is usually vulnerable to injury, where you can see a high signal in the T2 weighted image denoting muscle edema. And these are the most common muscles at risk: the hamstring, the rectus femoris, the medial gastrocnemius, and the biceps brachialis muscle. Clinically, the muscle injuries are graded into three grades. Grade 1 means pain, grade 2 pain and weakness, grade 3 pain, weakness, and loss of function. Then if you look here, and you can see that uh, the adductor muscle is on the right side, is of a relatively bright signal. You remember this is the adductor brevis, and actually in the T1 weighted image you cannot see significant changes because edema is black in the T1 and the muscle is also dark. Then you cannot see the changes. While in the T2 weighted image you can see edematous changes, and these changes are best appreciated in the stir image, where you can see brightness compared to the darkness on the muscle around. And this is also a adductor longus muscle edema. In the axial image, it's the site of the adductor longus, and in the coronal image, you can compare this muscle by this one, and you got in this T2 weighted image some muscle edema, as you can see. If you see muscle hemorrhage, which is diagnosed by the presence of high signal in the T1 and high signal in the T2, and this means that you are dealing with grade 2 muscle injury. And this is also an intramuscular hematoma, bright signal in the T1 and bright signal in the T2. In these cases, you know the T1 from the T2 by the signal of the fat. Fat is bright in the T1 and less bright in the T2 weighted images. Grade 3 muscle tear means that the muscle is lacerated and later on became atrophic. And you can compare this biceps femoris, this is the normal one, and this is a chronic injury, grade 3 of the muscle, which is atrophic, replaced by fat, and there is considerable thickening of its tendon. And this is one of the good examples of avulsion of the adductor longus tendon. This is the normal tendon inserting into the pubic bone, and here the tendon is avulsed and is its site is replaced by fluid signal. Then in this example, of course, you do not see anything in the plain film apart from maybe fractures or avulsions, But in the MRI, you see the adductor longus muscle contains high signal in the T1 and high signal in the T2, denoting muscle laceration and hematoma. And you also see bright signal in the adjacent muscles, denoting muscle edema. In the coronal images, you can see avulsion of the or partial avulsion of the tendon and the laceration of the muscle, the adductor longus muscle. This is also another example of avulsion of the adductor longus. Uh, this is the normal side on the right side, and this is the avulsed muscle with a gap and the fluid signal occupying the gap, as well as part of the muscle fiber and intermuscular fat planes. Then the hamstring inserts into the ischial tuberosity, and this is the normal side where the hamstring tendon, which is black one, inserting into the ischial tuberosity, and this is an avulsed tendon from its insertion site with a small gap containing fluid. And this is also a bilateral avulsion of the hamstring tendons from the ischial tuberosity. You see the tendon, you see the gap, and the gap is occupied by fluid compared to the normal appearance of the hamstring insertion into the ischial tuberosity. Then we came to what's known as Morel Lavalier lesion, and this is a kind of injury resulting in shearing between the skin and the subcutaneous fat. Then this shearing mechanism will disrupt the vessels and the lymphatics, piercing the fascia, and consequently there is leakage of lymph and blood in the subcutaneous space, resulting in formation of a big cystic mass at the site of injury. The lesion is more common in the trochanteric region and the proximal side. All what you can see is a big cystic lesion with tapering margin containing fluid. The lesion is treated conservatively, but if you drain it percutaneously, it will recur. And according to the literature, it should be managed surgically. This is an example of the lesion where you got a big collection of fluid showing low signal in the T1 and high signal in the T2. This fluid will later on show some changes in the signal due to the aging of its blood content. And this is another example. You see a swelling in the subcutaneous area, and this swelling is better demonstrated by ultrasound, where you can see the fluid content. Then we came to the snapping hip syndrome, and I think this video will also show better information concerning the snapping hip.
Snapping hip syndrome. Snapping hip is a click in the hip when the patient moves the hip. It may or may not be painful. It can occur due to three types of conditions: internal, external, or intra-articular. Internal, iliopsoas tendon is snapped. The snapping of the iliopsoas tendon occur over the iliopectineal eminence. The iliopsoas tendon will snap over the brim of the pelvis. It's caused by inflammation of the bursa that lies between the front of the hip joint and the iliopsoas muscle or tendon. Diagnosis is usually difficult. Ultrasound or MRI may be normal. It may reveal bursal fluid anterior to the hip joint. The iliopsoas tendon injection can be diagnostic. Abduction and external rotation of the hip and hearing the snap, the click, will help in the diagnosis. External type means outside type, called iliotibial band syndrome. The iliotibial band is thickened and it snaps over the bony area of the greater trochanter of the femur. The patient may develop trochanteric bursitis, adhesions, gluteus maximus, inflammation, or edema. Diagnosis of iliotibial band syndrome. Direct palpation of the greater trochanter. Put the patient on the side, put the hip in extension, rotate the hip and feel the pop. The best clinical test is Auber's test. It assesses the tightness of the iliotibial band. How do you do it? The patient will be on the side with the unaffected leg at the bottom. The examiner will abduct the leg and will extend the hip. The examiner will leave the leg of the patient lowered. If the test is positive, then the patient cannot abduct the leg past anatomic neutral. Because the IT band is tight, the knees of the patient will not come together. Intra-articular type can be a hip joint labral tear or a loose body. Painful labral tears are other causes of snapping hip syndrome. In the labral tear, the patient will suffer from decreased range of motion and a painful click in the joint. The labrum is a black triangular structure, and lateral to it you find the lateral recess. The dye can go there and it is normal. It is not a tear. When the dye is medial to that black triangular structure, then it is a tear. The MRI arthrogram is the best study to diagnose labral tear. All my videos.
Okay, then we have 2 or 3 types of snapping hip syndrome. The external snap, which is due to the iliotibial band moving against the greater trochanter. The internal type is related to the iliopsoas tendon moving along the anterior aspect of the hip or the iliopectineal line. This is the internal snap where the iliopsoas tendon will move during the hip motion along the anterior aspect of the hip, resulting in the snap or the sound. As he mentioned that the findings on MRI are usually non-specific. You may get some iliopsoas bursitis, inflammation of the bursa along the anterior aspect of the hip, and we see paralabral cysts or edema of the muscle itself. And this is an example of iliopsoas tendinopathy. You know that the iliacus and the psoas muscle tendons will join together before they reach the insertion site in the lesser trochanter. And here you can see the one of the tendons and the other one is of right signal, and you follow the tendon until they almost join together here before reaching the insertion site in the lesser tuberosity, and this is due to iliopsoas tendinopathy, which is considered one of the causes of internal snapping. And the intra-articular snaps are due to an intra-articular abnormality, which is mainly related to injuries of the acetabular labrum, as discussed before, and the presence of intra-articular loose buds. Then finally, we came to the athletic pubalgia, which is mistakenly known as a sports hernia. The athletic pubalgia is related to the what is known as the core muscle injury. The core muscle is the insertion of the distal part of the rectus abdominis together with the adductor longus in the anterior aspect of the pubic symphysis. And this insertion site is prone to some degeneration, some tears, and this will result in what's known as athletic pubalgia, which is a frequent cause of pain near to the hip. The typical presentation in athletes is insidious, persistent, or gradually worsening groin pain. Then what can you see in the MR images is affection of the pubic symphysis in what's known as ostitis pubis. There is bone marrow edema of the pubic bones. There is irregularity and the erosive changes sometimes, and also you got some widening of the pubic symphysis. The core muscle is present here and in the inferior aspect as well. Then you may see some fluid between the core muscle attachment, and you may see complete rupture of this tendinous origin. The additional findings of core muscle injury include adductor longus tendinosis, rectus abdominis or proximal adductor myotendinous strain, or distal rectus abdominis muscle atrophy. Ostitis pubis is a related and often coexistent entity of this athletic pubalgia. You got osseous stress, and this will present by bone marrow edema on MR images. And here you can see the irregularity of the pubic bones. You can see the bone marrow edema, and also you can see fluid underneath the core muscle insertion. Another example of athletic pubalgia due to or associated with ostitis pubis. In here you can see widening of the pubic symphysis, irregularity of the edges of the pubic bones, and also bone marrow edema of the pubic bones. Thank you very much. Alhamdulillah.